What made you become a doctor, Dr. Paquette?
Um, my becoming a physician is a fortuitous happening. There were no intentions of my becoming a physician. My initial intention was to enter the ministry, and when I decided to enter seminary, I found that the people with whom I was to enter seminary were not to my liking. And my father had well prepared me in my education and asked me to take all courses, sciences and arts and things like philosophy and whatever else, languages, so that I would be prepared to do anything in life. When I had to take a second choice, I applied to medical school. I was rejected out of hand at 3 of them and was asked to interview at Georgetown University. I went down for the interview and was actually examined by the professor of physiology. He then returned a telephone call to the initial interviewer, who then told me that I had been accepted. And therefore, I was lucky.
What year did you graduate?
In 1963, I graduated from medical school.
Well, I don't have too many specific questions about your training, but is there anything that you would like to talk about from medical school or your residency or internship before you practice?
Yeah, I had no intentions of becoming an orthopedic surgeon or even going into surgery. And therefore, my becoming an orthopedic surgeon happens to be a stroke of luck also. It just happened that during the program while I was here in Worcester as a resident, I was obligated to prepare for the professor who was a visiting professor from Georgetown in orthopedics. And there were 2 days of presentations which were necessary. And so I really boned up on all of the things that had to be prepared. And lo and behold, at the end of the 2 days, he said, "Charles, I wonder if I might speak to you at 10:30 in my room tonight." I had no idea of what he was going to speak to me about. I went to his room, and he said, "I'd like to offer you a position in my program." Now, I had no idea. I did enjoy the orthopedic rotation. I enjoyed the urologic rotation. I did not enjoy general surgery. So I went to speak to my wife, and I accepted his position. But I have no illusions about that offer. It was the Vietnam time, and many of the residents in all programs were being sucked into the military, and there were deficiencies. So I was well aware that my acceptance into the program was to fill a slot.
But that didn't sour your experience?
Not at all.
Good.
I had a wonderful time in residency, as much as you can have a good time in residency. It is a very difficult time. In those days, we worked every other night and every other weekend, and at the hospital in Worcester where I served, I was making $2,800 a year. At that time, I had 2 children. My wife was pregnant for a third. He said, "I'm sorry, Charles, but if you take this position, you will have to accept a $1,000 cut." Therefore, I had to go to Washington, D.C. and live on $1,800 a year. Fortunately, my wife did earn some money.
Do you remember how much it cost for you to go to medical school?
Yes, I do. It cost me about $12,000 in tuition fees, plus all of the extras that were necessary. And that's pretty much what my parents and myself, through what I had saved, had to come up with.
Okay. Did the costs influence you at all in terms of where or how you practiced once you graduated?
No, I'm a family man. All of my family is here, and I married a girl that was local to this area. Therefore, my intention was to return to my home, and I'm very happy I did.
How do you think med school students today are influenced by the cost of school? I mean, in terms of their choices once they graduate.
I unfortunately have no opinion on that. I don't know. I certainly know only how our residents come to us. In orthopedics, we would say that we have the cream of the crop, the absolute best residents from the best colleges who have done exceedingly well in their program, and we're extremely pleased to have these residents to work with us.
Describe a typical day of practice when you first started here in Worcester.
Oh, back in those days, the first thing that I was told as I entered the operating room for my first case is that I was a member of the courtesy staff, and I was to understand that I would never get a morning time. Well, it just so happens that I had joined practice with another doctor, and he had all of the morning times, so I was delighted to take afternoon times. And I had what you'd call a leisurely schedule with nobody behind me and nobody to push me on with my surgical cases. So that I had morning office hours, and I still have morning office hours and love them, and I had afternoon surgery. Well, that didn't, they thought that they were going to upset me by telling me that I had to work in the afternoon. I loved it. When they found that out, I think it was about, maybe a month later, I started to get morning times, and that really fouled up my life. Because I now had to balance my office hours with surgical times, and in those days, we were privileged at 5 hospitals. I worked at City Hospital, Fairlawn Hospital, Holden Hospital, Hahnemann Hospital, Doctors Hospital, and when needed, we had to go to the state hospital to take care of fractures there. We would even operate at the state hospital. Well, to make rounds at 5 hospitals and balance office hours and a surgical schedule meant that you had to get up early in the morning and that you didn't finish your rounds until late at night. It was a lot different than it is now. I work now at 1 hospital.
Which hospital is that?
I work at the Memorial Campus of UMass Memorial. My day starts at 4:45 in the morning. I'm in the hospital by 5:45 in the morning. I make my rounds at the same time as the residents. I get to speak with the night nurses who tell me what has gone wrong, if anything, with my patients. I speak to the residents who tell me what has happened relative to my patients. And I'm in the office for 7 o'clock office hours in the morning. And it is now 4 o'clock in the office in the afternoon, and I'm still here.
How have your hospital rounds changed over the course of your career?
Well, I don't have to go to 5 hospitals now. I only have to go to 1. And I don't have to make rounds at night because they're done the first thing in the morning. And that is an ideal time to make your rounds. You get your dressings changed, you look at your wounds, you check the the intake and output on the hospital record, you check the blood counts that have been done the night before. It's a wonderful time. And all of these things are in the computers right away. So you know all of the numbers right away. It's a good thing. I enjoy my rounds more now than I used to.
So it seems like you were influenced a lot by what time you were practicing, whether in the afternoon or morning. I mean, was that too big a deal, or?
Well, I still enjoy morning office hours. If I start my day at 7 o'clock in the morning in the office, it's obvious that I enjoy morning office hours. There have been times when we have had so many patients that we have had to back book our patients up to 6:30 in the morning to see them. And patients have wondered what's wrong with this office that we have to do that. There's just no time.
How did you communicate with your patients early in your practice, outside of the office and outside of the hospital? Did you ever make house calls?
There were rare occasions when house calls might have been necessary, and these were occasions where a cast might have been problematic, especially a cast in a patient who had a total body cast and couldn't easily be mobilized to a hospital setting. And so we would bring saw cast supplies and repair a cast. We still go to nursing homes. So if you consider that a house call, if we get a telephone call from a nursing facility and it's a simple matter of taking off a cast, putting on a new cast because it's been soiled by the patient, we can do that in that setting, and we don't have to bring the patient to the hospital. We are very cost conscious about handling patients.
And what other ways would you communicate with your patients? Would you talk to them on the telephone often, or prepare you deeper?
We answer all of our telephone calls. We always return messages. However, nowadays, we return messages only in the office setting when the chart is in front of us and we can document the nature of the telephone response. In the olden days, unfortunately, there wasn't as much documentation that was required, and a lot of what might have been said on the telephone was never documented, and so that was a problem.
Who were your patients in general, and where did they come from? Were they all from around the Worcester area?
No, our patients come from as far as Leominster, Fitchburg, northern Worcester County. The majority of our patients will come from Worcester, West Boylston, Sterling, Princeton, Paxton, Holden, Oakham, Barry, Leicester, Spencer, Brookfields, occasionally now Charlton, Oxford, sometimes as far as Webster, rarely from Grafton, and rarely as far as Northborough, Westborough, because they're closer to Framingham.
Do your patients choose their physician? Did they have the chance to choose their physician early in your career?
Oh yes. Early in my career, the patients needed no referrals, and they could come to my office anytime that they wanted. And oftentimes, the physicians who knew me because I was of service to them in the hospital setting would refer patients to me based on whether they liked me or not.
What do you think it was like for your family to have a physician in the household?
I think my mom and dad may have had a certain measure of pride, but I never lived in their house while I was a physician. I was always a married person and lived with a wife even before I graduated from medical school. And it's interesting that my brother is also a physician, and he's gone into the least practical aspect of medicine. He's a psychiatrist. And it probably reflects also the differences in personality that my brother and I have shown over the years. I don't want to go into that. It has something to do with his side of the room that we shared being messy, my side always being neat, a lot of things like that. His socks were under the bed, mine didn't have socks under the bed.
Did you take vacations early in your career?
Yeah. I took vacations with my family. We always took a vacation 2 weeks in the summer, and we always would go to the shore. But the majority of the time, we have gone to one place on Cape Cod, Orleans. At the present time, I just came off of vacation, and my wife, my 4 children with their spouses, and my 14 grandchildren, all were under one roof. I had to work 5 weeks to afford a 2-week vacation. However, there are rewards to doing that.
Okay, well, now I'm going to move on to the science of your practice. Could you tell me what the most typical illnesses were that you dealt with early on in your practice?
Yeah, the most common illnesses that we would see are the illnesses related to aging of tendon. Tendinopathies were the most common things that we would see.
All right, and how did those illnesses change over subsequent decades?
Well, when I first started treating tendinopathies, cortisone tended to be a very common item in usage. We've now discovered that cortisone actually weakens tendon, shuts off the healing process, and actually has some deleterious effects to the tendon that we were treating, even though it would relieve the patient's pain. However, even if you didn't treat a tendinopathy, the majority of the times, if left alone, a tendon will heal. And that tends to be my current advice. And I only now inject with cortisone those patients who have such severe pain that they can't even sleep with this pain. Unless they ask me to inject them after I give them my instructions as to what the deleterious effects are, and they want it anyway, I will tend not to inject.
All right. Did any new illnesses arise over the years? Has it always been tendinopathy?
Well, orthopedics is a pretty practical specialty, and basically most of the stuff that you see will be visible on an x-ray, and therefore what was seen then is what is seen now. The treatment, however, has changed.
What have you seen as one of the most important breakthroughs in treatment?
Well, when I first started practice, we really had very poor treatment for arthritis of the hips and knees. Now, we can take a patient who is crippled with an arthritic process, we can introduce an artificial joint into this patient, and they are universally happy. There are very few exceptions to that, and we can make somebody have a wonderful quality of life for many years after these operations. These did not exist when I started practice.
Have you seen any breakthroughs in prevention, disease prevention?
Yes. We recognize that severe back pain, osteoporosis, failure to heal wounds, high risk of infection, are very much related to a smoking habit. And the most wonderful thing that has come along is an education of the public as to the fact that most of the preventable diseases today relate to smoking. I'm only quoting Dr. Koop, who said that.
Could you describe how attitudes towards smoking and cancer have changed throughout your career?
Well, smoking was not known to be a cause of cancer when I first started. And then it became known as a cause of cancer. And then it was now described as a cause of degenerative disc disease in the back. And then it was found to be related to osteoporosis. And then it was related to a failure at healing of fractures. It went on and on. It is amazing how smoking relates to so many things. Yeah, we discourage it. If we see a patient with a fractured hip and we pin it and expect the fracture to heal, we tell the patient, if you don't stop smoking, you may not heal this fracture. If they don't heal the fracture, fortunately, we have Plan B and Plan C. We can make them walk, but now we have to use artificial means.
What is something that doctors take for granted now in terms of technology that you didn't have at some point in your career in medicine?
You really want to know the biggest thing that happened in terms of fracture treatment was operating room fluoroscopy. This is an X-ray technique where you can see what you're doing as you do it without making big incisions. It allows us to stabilize major fractures of the femur or tibia or even shoulder by slipping rods down these bones under the control of an X-ray. We didn't have that in my day. In my day, we had an X-ray machine. You would do a procedure. You had to, if you were doing a hip fracture, you had to have an X-ray of the front projection and the side projection. You would put a device part way in and you would wait until they developed the film. That was 10 minutes. And if you didn't like what you saw, you had to reposition the device and take another X-ray, and you had to wait another 10 minutes. Now you can watch yourself put the thing in where it's supposed to the first time. And that is one of the major advances that we've seen.
What technology is still used frequently today that you used back in medical school or early in your practice?
Well, we still use X-ray. I have an X-ray machine in my office. I have to have one. I can't take off a cast with any sense of well-being unless I know that that fracture is healed, or that it's straight, or that it's where it's supposed to be, so that that technique is universally applicable, and it hasn't changed over the years, although we have faster films requiring less radiation. So that's certainly one of the things that we as doctors need.
Right. Have many of the other procedures remained the same, or?
Oh, certainly our approaches to the various parts of the body have not changed. And that's why, if you had never been trained in a total joint replacement, you still use the same technique of getting in there as you used when you did a regular prosthetic replacement, which was not a total hip. And we've been doing those since the 1950s, I believe. And that was well before I started practice, and I was trained in the doing of this procedure. And it was only a mild modification of this procedure to do a total hip replacement.
Did you have access to new technology in your field?
Always do. We are constantly being detailed by companies that make new instrumentation, and if this instrumentation makes our life easier, we're very anxious to adopt something that's new. However, there is always a cost factor, and we have to weigh our desires against the cost of the new technology, and if it's something that we desperately need, we will ask for it and wait for it. Right at the present time, our needs are minor. We have just about all of the toys that we need to practice very comfortably.
What would you like to see invented in the medical field?
And not being very innovative myself, I'm afraid I'd defer on that question. I don't have a good answer.
Okay. What were some of the most important drugs that you used early in your practice, and how have those changed?
Well, one of the drugs that I used to use very frequently was a drug that was called butazolidine. Butazolidine was one of our first anti-inflammatory drugs, and it was a great drug. Worked wonderfully. It worked as good as the current ones that we have. However, too many people developed bone marrow suppression. We don't use it anymore. So it was a great drug. We used it for anything for an acute thrombophlebitis of a superficial vein to any arthritic symptoms. For gout, it was a wonderful drug. We don't use that anymore. We still use cortisone. And cortisone has remained a mainstay for certain things like joints that are inflamed, that the patient is so uncomfortable with that they need an acute relief. If you take a gouty joint and you take the fluid out and put some cortisone in with an anesthetic, you can give them almost immediate relief. They think you're akin to God when you put something like that in, but that really is the anesthetic that's working, not so much the cortisone. Another drug is the long-acting anesthetic. The long-acting anesthetic and its delivery tools has allowed us to do short-stay surgery without much in the way of pain. We can do major shoulder surgery, and we can instill a small catheter that will deliver Marcaine over a 24-hour period, and the patient won't even have to take a pain pill. He'll have total relief. However, after 24 hours, he has pain.
What major breakthroughs have you seen in drugs? Besides those you might have already.
Even though we have these drugs called COX-2 inhibiting drugs like the Celebrex and the Vioxx, which purportedly provide less irritation to the stomach, I don't think that that is a major breakthrough, because it really doesn't work any better than our previous non-steroidal anti-inflammatory medications. The big breakthrough has been in the antibiotics that have been developed over the course of my practice years. When I first started, we have penicillin and streptomycin. We have a plethora of medications now, and even these drugs have been demonstrated to have resistance to certain bacteria because they've been used so much. But those are the drugs that have been the biggies.
Have you always had access to the drugs that you wanted to use?
Yes. I have had access to anything that I have needed to use. Although I must admit that when I first started practice, there were people in the city of Worcester who were absolutely adverse to prophylactic antibiotics at the time of surgery. That opinion has had a total reversal. Now we use prophylactic antibiotics regularly. But some of our infectious disease brothers were absolutely adverse to our use of these. They thought that they would create resistance in bacteria, and that's true, but it also has prevented a tremendous amount of disability, especially with our total joint replacements. Should they get infected, it's a disaster.
Okay. How have changes in drugs and the drug industry affected your practice?
As a surgeon, I don't use drugs very much. I use pain pills.
That's right.
That is the major thing. And you want to know something? Pain pills haven't changed. They're still morphine-related drugs. So they really haven't changed too much.
Okay. Could you tell me how patients without money received health care early on in your practice?
The same way as they do now. If they don't have any money and they need care, even this office will make sure that they are cared for. We will make sure, for example, that I see them in a clinic setting where they have applied for free care, and in instances like that, I have no problem in giving my services. The difficulty is it should not cost the doctor to give free care. And in this office, the minute somebody comes in and has to have an x-ray taken and take up a 15-minute slot and have a cast put on and have dressings changed or something like that, immediately it costs me as a physician. And if I were to do too much of that, I would have a major problem in making ends meet, because I'm in a high overhead situation. However, since the hospital receives reimbursements for free care rendered, if we see the patient in the hospital and we give of our time in the clinic setting seeing these people, and even operate on these people if necessary, at no charge, it doesn't cost us.
So do you think that everyone who has needed care has received it?
Absolutely.
Over the years, how do you think Worcester's compared to other places in terms of providing care for the underserved?
I wish I could tell you that, because I don't know about other places. I just know how we do it in Worcester and how we make arrangements for our people. And I know that they are well cared for.
So Worcester's just been great by itself, but you can't really...
Well, I can only speak about the orthopedic sphere. We have no problems in ordering MRIs, doing total hip surgery or total knee surgery, or taking care of major fractures at no cost, as long as the patient is seen in the clinic setting.
Mm-hmm. What were some fears and concerns about socialized medicine in the 50s and 60s?
Well, the government has never done a very good job, and I'm not so sure it's even the province of the government to be involved in a socialized one payor system, because I'm really a Republican, and I believe that yes, the government should fund a military for the protection of the country, but then it really has gone far afield, and it does a heck of a lot more than that. And I'm not been unsatisfied with the system as we have it now. Each state provides insurance for those that can't afford it and who qualify. They have a Mass Health in Massachusetts. I don't believe that the federal government has any business in this field.
What were your feelings on Medicare and Medicaid when they came into being?
Well, I'm well aware of what happened to the elderly who broke their hips prior to Medicare. Unless they had some private insurance, they were not cared for by private doctors. They were put in a ward and they were cared for by resident physicians. Okay, that immediately changed when President Johnson instituted the Grand Society as he envisioned it and Medicare. All of our elderly patients, and they are our best patients, were well cared for. They are the least complaining of all patients. They're wonderful.
So do you think that the government has become more or less involved in healthcare throughout the course of your career? It would be more involved, right?
Yes, they have become more involved during my career. The government is, and it continues to be. They're now debating the prescription coverage for the elderly. And I think that there may be some legislation in the works relative to physicians providing assistance to the uninsured, but there will be a malpractice cost to the federal government. Our lawyers have not allowed us to give free care to the uninsured without having malpractice.
So how else have you seen the government's increased involvement affect physicians?
Well, in terms of reimbursement, as the federal government goes with its reimbursement policy, there too tends to go the private insurers. If the government has been wealthy, I mean, they have provided a good reimbursement. In those days, the private insurance companies had good reimbursements. As the federal government decided that it could no longer afford good reimbursements and started to cut back, we have seen cutbacks in the private sphere.
How have you seen just the public's general access to healthcare be affected?
I really think that everybody has had, from the orthopedic standpoint, I haven't found any problems in their being taken care of. If a patient breaks a bone and ends up in an emergency room, they have to be taken care of. This is an emergent situation, and they are cared for. Whoever happens to be on service at that time is obligated to take care of them, whether they are some of our quality citizens with very good insurance, or whether they happen to be intoxicated, in poor, it makes no difference. They are still taken care of. But that's orthopedics.
Yeah.
And a lot of what we do is not elective. It is urgent.
When did HMOs first impact your practice?
That's when our reimbursements changed. I don't remember. It's been 10 years probably or more.
And how exactly did they impact you? Obviously your reimbursements, right?
Well, they impacted who could see us and what kind of gyrations they had to go through just to get seen in the office. And our office had to adapt to all of the machinations of making sure that there were referrals, that we had a piece of paper in our office that indicated that we would be reimbursed if we saw this patient. Oh, the front desk has to be a contortionist in order for me to see a patient, and they do their job very well.
Well, do you have any further thoughts on the government and medicine, or managed care before we move on?
No, I really, I do feel that at some point in time, the uninsured need to have some protection, but I don't have a solution because it's going to cost somebody a lot of money to insure all of these people, and I just don't know how it can be done. And I assume that my dilemma is the same dilemma as those people who legislate. They can't find a solution either.
How have doctors' salaries changed over the course of your career?
I make less money now than I did. I can be very frank with you. I'm salaried at $125,000. I'm about to retire. I have advertised this practice on the internet. I have interviewed 6 people, and not one of them has been willing to undertake my practice for that amount of money. And not one.
So where has most of your income come from throughout the course of your practice?
This is a corporate practice in this office, and I've been salaried from the first day that I worked here. And my salary was $30,000 the first year, $60,000 the second year, and I don't know what it was thereafter, but it has never. Yes, there was a time when it was $150,000, and then we found that we couldn't do it, and we had to ratchet it back. And if there was anything left at the end of the year, we might take a little bonus or something, but that hardly ever happens.
Okay, well, you mentioned malpractice earlier, but could you tell me more about how malpractice insurance has changed over the years and how its effects of doctors' practices have changed?
When I first started practice, if we had malpractice insurance, it was a very small amount of money. And then people started to institute litigation against doctors because our attorneys would monger this type of dispute, and they still do. If one simply watches television, you can see that they are encouraging disputes, even for perceived injury. And of course, every surgery injures somebody, doesn't it? It does something. No one that I know of is out to do bad things to somebody that's a doctor. I suppose occasionally there's some sensationalism that hits the news about one individual. I'd like to discard those happenings. But in any case, malpractice started to gradually increase, and we used to pay more and more premiums. And one year, the state said, we are now going to charge you back because we charged you too little for the past several years, and you have to come up with $300,000 for your malpractice in order to maintain your coverage. I am going to tell you that that year was a disaster as far as we were concerned in terms of making ends meet. And that is not an exaggeration. Those are the actual figures. It's terrible.
Yeah. I mean, that's just 2 years' salary, right?
Yeah, that's right.
Well, how did you learn the business of medicine?
I had a senior partner at one point in time who gradually introduced me to that, something that I would have been willing to do with any, in fact, have done to my junior partners who have already retired. They were introduced into the business of medicine and gradually learned, and I still attempt to teach my resident staff some things about the business of medicine. However, the business of medicine in private practice, as far as orthopedics is concerned, I think in this city is dead.
Yeah. Well, do you think that medical economics is a topic that could be covered more extensively in medical school? Or should that be?
It could, but I doubt very much that it should be in the field of orthopedics, because no one is willing to take on the overhead that is required of a place like this, where there is a building, an office, a parking lot that needs to be plowed, sanded, cleaned, relined, heat, lights, air conditioning, furnaces that need to be repaired periodically, employees, the employees' health insurance, equipment, x-ray, photocopiers, computers, all of these have to be purchased in private practice. No one is willing to assume that kind of a responsibility nowadays.
What are some changes that you've seen in the demographics of the Worcester community?
It's becoming part of Boston. Worcester is now only 45 miles from Boston, and people are traveling to Boston all of the time in greater numbers. We are now a suburb of Boston. We are an extension of Metro West. The real estate in Worcester is skyrocketing in cost. The towns that surround Worcester, which used to be towns where you would see everybody with a pickup truck, you will now find living in they used to live in, you know, very extremely modest housing. These same people now live side to side with very upscale houses, and so we now have towns like Sutton and Rutland and Oakham and Sterling, which used to be towns that had blue-collar workers alone, now have executives and big homes, all of which are over $300,000. We have had a big sprawl, and many of these people are traveling east for their work. In Washington, D.C., where I trained, people travel 70 miles to get into Washington every day in horrible traffic. I suspect that we're going to be seeing something similar to that as Boston grows ever closer to Worcester.
Has the ethnic background of your patients changed over the years?
Oh,
Or how has it changed?
Worcester used to be an enclave of ethnicity. I am Franco-American. I can still speak French. I came from a Franco-American section of Worcester. Worcester used to be Irish enclave, Lithuanian enclave, Polish enclave, Jewish enclave, black enclave, Swedish enclave. All of them are surrounding their temples or churches, and we no longer have that. We have a true admixture of people who no longer claim much in the way of ethnic backgrounds. So it has changed. Worcester has changed in that regard a great deal. My practice serves no particular enclave. I can still speak to the occasional French person who needs to have French spoken. We have had a huge immigration of the Hispanic population in this area, and I'm happy to say that we have a person in this office who speaks wonderful English, better English than I speak, who is extremely fluent in Spanish, and we can service these people with no difficulties whatsoever.
What changes have you seen in women's health in the Worcester community over the years?
Well, I'm not involved with women's health in particular. We're well aware that women fracture their hips much more than men, but that has not changed over the years.
Okay. Could you comment at all on changes in children's health, or should we skip it?
I think we have to skip children's health too, because I'm not involved at that except for the injury aspect.
Yeah. And obviously you've only practiced around here, so you couldn't compare Worcester to any other place.
That's correct. I've practiced here all of my 33 years.
Well, how have public perceptions of doctors changed over the years? You can answer that one, of course.
Yeah, I think generally patients like their doctors.
Yeah.
They don't necessarily like all doctors or doctors in general, but they like their doctors. And I think that will always be the case. It's always a matter of personality. Patients, unfortunately, are ill-equipped to make judgments on competency. I think the only people that can judge competency are other doctors, and they know the general competency in their own sphere, and sometimes in other spheres. That's all I'd say on that.
How has the role of the physician in this community changed over the course of your practice?
I'm not certain that I have any opinion on that. I think what I did in 1969 is what I do today, only I do it better with better tools. And that's as a physician. My life is easier today than it was back there. I am not politically active, at least not in medicine.
But certainly, I mean, the business side is going to be a much bigger part. I mean,
Well,
it's one aspect of medicine, right?
Actually, business, no, I'm not. You know, this company now runs itself. Everybody has their little job, and it runs itself. It does not need to be run by me. I don't. All I do is ask the office manager, do I have enough money to get paid this week?
What was it like for the female physician in Worcester in the 50s and 60s, and how has the experience for the female physician changed since then?
Oh, I can tell you some of the things that used to happen when we would interview a woman physician for a position in the orthopedic section, and that was in Washington, D.C. Now, please understand that that's way back in the 1960s.
Right.
My professor, I would sit in on the interviews, and he pulled no punches, and unfortunately, he would be sued unbelievably if he acted today as he acted then. He would ask a young prospective resident in his program why he felt that he should choose her as a resident over a gentleman. He would then ask her if she was married. He would then ask her if she expected to be married. Questions you cannot ask today. He then would ask her if she was ill often. He would then ask her if she planned on having children, And did she plan on taking a lot of time off from the practice of orthopedics to tend to her children? His whole thrust was to determine whether she really planned on a full-time commitment to orthopedics and not plan on family, something which nowadays is not done. His whole thrust was to determine whether he would be getting an adequate investment in the training of this young lady. You really can't do that anymore. I can understand why he did that, but you can't do that, no. Women are totally accepted now, and I think we have about 3 or 4 women in the orthopedic program at Women, and they are outstanding. They sometimes enjoy the fact that I do the brute strength aspect of the operative procedure, and I can understand that, and that's what an assistant is for. Yeah. It's to make sure that the operation goes right, and whoever's the strongest does some of the work that requires strength.
Are there Worcester physicians that you admired when you first started practicing here?
Oh yeah, yes. I have to tell you that one of the physicians who was in orthopedics that I admired the most was Dr. Philip Leahy, the senior physician. His kind personality, his generosity in teaching me led me to like the orthopedic rotation that I had in my early training years. He was a very good man.
Okay. Any others?
And I have no objections to mentioning by name.
Yeah.
His son currently practices in the city of Worcester and has a similar personality. Yeah.
All right. Any others you would like to mention?
No, I really, I could mention another one. Dr. Francis Waters was a very nice gentleman to me also. Yeah.
All right.
He still lives, by the way.
Good. What do you like best about practicing in Worcester, and then what do you like the least also?
Well, how about the fact that I live 10 minutes away from anything that I need to do? And if you travel at 5:45 in the morning, no traffic, and the lights